Hello, coding family. How's everybody doing? Let's see if I can't get this to work. There we go. Hey guys, how's it going? Great. Hey Rosalie. Hey Patrice. Hey Johns. Hey Moga. Hey Heather. Hey Marcy. Hey Michelle. Hey Love Muffin. Hey Renee. Hey Andrea. Thanks Blondie. Hey Gupta. I haven't posted the workshop I did yesterday into my store yet, so y'all could purchase it if you didn't make it to the workshop, but I can do that if there's interest, people that want to. Hey, Anointed. How's all the successful queens doing? Aw. Hey, Patrice. Hey, Flower. I don't know. Is there anybody taking the AAPC course? Hey, Go-Kart. How are you doing? Hey, Daphne. Beautiful place, Washington State. She's listening while she's studying for the CRC. Oh boy. I got to work on some notes for you guys. Hey Twinkle, how's it going? I don't have a ton of stuff prepped for you guys today because I had to work and then we had the workshop yesterday and it's just been busy, one thing after another, and I had to work all day today, so don't have a ton of stuff prepped for you guys. I'm still trying to get this OBS to work. It does not seem to want to show off my Word document. I don't know what's going on. I'm still sitting here trying to get it to work. Come on. I'm just sitting here showing y'all all kinds of stuff, but I'm trying to figure out how to get the Word document to work. It's just not working, and I don't know why. I think it's because, look at that, it'll show you how many documents I have, but it won't show you my Word document, really? Why? Why? Word has been giving me fits all day today. It's been slow and laggy, but I don't know why it would not want to show you the Word document. It'll show you everything else I got open here. Jeez. Why will it not show Word documents? That's not helpful. If OBS is going to be a pain, I may have to go to TikTok or something, but why? Why? I have have another Word document here. That's not helpful. That's not helpful. I've closed Word down, shut it down, opened it back up, brought it back up. Let me print it to PDF. It looks like it will show you a PDF, and see if that will help. Okay, not to that. I want to go to Microsoft PDF. Live 6-26. Gotta save it. That's not helpful. Still not helpful. Yeah, it still didn't even print it to PDF, even though I saved it. It's just something wrong with my Word documents. Let's see. Okay. Let me try just rebooting this computer and see if that helps. So you guys, I'm just going to disappear for a minute and I'll be back when I can. Let me see if this will help. Sorry guys, I don't know what else to do. My IT guy's here. I just hate to bug him because, man, I always sound like an idiot when he comes over here, and I get ridiculed for what I've been doing with all my tabs open and stuff. So anyway, I'll get him if I need to. Hold on, I'll be right back. Hey guys, I can't see chat yet, so I'm here, but barely. I just have OBS starting. Hopefully, I gotta go to YouTube real quick and grab that chat link and throw it into OBS so I can see chat. And then we'll see if the Word document's working. Come on. There we go. Let's go to YouTube. Get there. Go here. Pop out chat. Yes, 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 yes. And grab that link. Copy. There we go. I can see chat. Now let me see if I can't get Word document to work. I got part of it. Not what I want, though. I got something to show. I got YouTube to show, but I want Word document to show. There we go. Yay. Okay. Oh, I at least got that. Okay. I had like 52,000 pages and tabs and things open since I did the workshop and everything else this week, so I'm sure I missed a lot in chat, so I only saw what I have in chat since I rebooted the computer. So if I missed your question or whatever, just please post it again. Let's see. Oh, Cooped, I'm glad you're feeling better. Okay, y'all want to purchase the workshop from yesterday. Great. I don't have it up there yet, but I will do it as soon as I get off this live. Nicole says she's taken an app course through an approved instructor. So many have passed. Yeah. There's been a lot of people that passed. Somebody's working on the cardiovascular part of the quiz right now, or course. I took my test for the 3rd time, and I was just a few points away from passing. Somebody else got like 69 today when they took their exam. I had somebody make 100% on like their guidelines and anatomy and integumentary and just a ton. Oh, lab and path. Only missed one question there, but still didn't pass. It's like, oh gosh. Just got lower scores in the E&M section. Oh, thank you, Go Kart. You're always so sweet and saying to give the thumbs up. Thumbs up on the podcast that I haven't posted up today. I need to read a section of that, but I haven't had time today, but I will. Is also helpful, or any of the videos you see. Yeah, never give up. Don't let them win. I did do they have a special going on for like 5 more days where if you want to buy your membership, which you have to buy every year anyway, for $175 a year, and mine was due at the end of this month anyway, so I lucked out. I don't know. I just gave them $400 so that I could have a membership for the next 2 years, I guess. So expensive. Let's see. Thank you, Marcy. Hey, Jen. She's waiting on her resume from Project Resume. We go based off MDM for emergency. Let's see. We go based off MDM for emergency E&M. Yes. Yes, yes, yes. I think the E&M section gets me also because I was used to the 2022. Yep. They sure do know how to get money out of strugglers. They sure do. Hey, everyone. Cynthia, she says she's new to the group. She's so glad she found. Aw, thank you. It's my mama's name is Cynthia. 2 out of 3, right? Unless they're a new patient. If they're a new patient, but we're not talking about ER, because ER doesn't matter if you're new or established. But new patients are 3 out of 3. All 3 have to match. But for established patients, yes, we are 2 out of 3. What about code 36222? What's going on, Suzette? What did you want to know? Y'all ask away too. Don't forget to join the Discord group, because once you do pass, there's a room in there where I've posted a couple of years worth of information on like employer coding exams. If they give you an exam and want to see how well of a coder you are before they hire you, I have posts and the questions and stuff of those particular type of things. If you have issues or questions or need help, you can post in there. All right. But there is 2 years worth of information in there. You can scroll backwards and look for information in Discord. Let's see, 6222. I know Discord's wanting me to update some stuff I haven't updated yet. Selective catheter placement for a common carotid artery. We're unilateral, any approach. We're artery. All radiation and supervision is included. We're going through the cervical branch arch, which means we're up in the neck area. What's your question about 36222? Selective catheter placement means that we are further away from our destination when we place that catheter. We're not super close to like the jugular when we do this. We might be down in the chest in the brachial artery area, but we're going to slide on up to that jugular. Thank you, Twinkle. Twinkle gave away a membership to Suzette. Awesome. Can you look at them? Yep, I'm looking at them. What you want me to say about them? Let's see, our 6223. Two 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 is, cervical cerebral arch, where 223 is of the extra cranial arch, carotid arch. So and then our 224 is extra and or cervical cerebral, but we are doing so the 222 and 223 are common carotid or innominate artery, where our 224 is internal carotid artery. Our 225 is subclavian. 226 is vertebral. The other two, 227 and 228, are add-on codes. And you can see those differences if you look at them through Appendix L's eyes too. So if you're back in the back, I can show that off probably if I can get my camera to come up. 222 is cranial. 223 is extra. It's also cranial and cervical. But 224 is the internal carotid and extra. 225 is subclavian and innominate. 226 is vertebral. 227 is extra carotid. 221 is aorta, where 222 is artery. So is 223, 224, 225, 226, and 227 are all artery, but 221 is aorta, which is always neat and interesting and different for me. Let's see, what did she say? Let me catch up on chat here because I've been just talking away and not looking. I have some problems on my side when I try to join. Make sure you have, when you do the Discord, you've created your own account with your own email address that it's attached to your device, whatever you're logging on with. You've gone to that email address, you verified that your email address is correct with Discord. Then when you click on my link to join in my Discord, you won't have any trouble getting in and logging on. They won't let you in if you haven't verified your email address. There was a question on the exam about these, and I can't remember exactly what it was, though. Between the 36222, 36223. Well, let me get out that pink highlighter then, because I assume you're talking about your coding exam for certification. Jen, can you talk about? Yep, I can. Ahmed, I have a question. I got 2 exam practice bundles from AAPC. I'm scoring 35 to 38, and I can't seem to pass the 38 mark. The ones that you are getting right or wrong, no matter what they are, go find out, Ahmed, why each answer is correct and why each answer is incorrect. What inside the books tells you that it is incorrect, especially for the ones that are code-based, like this 36221 and 222 and 223. If we have practice exam questions with these codes in it, there's going to be something here, whether it's a parenthetical that tells you don't use 222 with 37215. If one of our possible answers is that, then you know that that's why the answer is wrong. Sometimes it could be something in the guidelines, like there is a little paragraph on page 289 in the second column that starts out right before you start coding 36221. One tiny little paragraph that starts out when arterial or vessel bypass graft angiography is performed in conjunction with a cardiac catheterization. We're supposed to also see some 9000 codes. They also have another bold print that talks about the medicine section, when internal mammillary arteries angiograph only is performed without a catheterization, we're supposed to go see the 362, 16, and 17. These type of hidden little areas are where a lot of times AAPC gets their question. Did you notice that little sentence there? Because they could put a 36216 as a possible answer, but also have it with these 36221 and 222. But if you didn't notice that little do not, it's technically what it is when you're doing a mammillary artery angio only without the catheterization, then we're supposed to be in the 216 area. If you didn't notice that, then you might skip over, and they might put 3 of our answers all in this 36222 area and do different combinations, but only have one little weird outlier where our answer is 36216. And you might think that that outlier is an outlier in there for no reason. But if there's a parenthetical near it or around these codes, that's where they put that one little weird question that is an outlier that might mean the difference. But really analyzing those practice questions and the answers and why they came up with the answers and why every single wrong answer is technically wrong and what in the book tells you it's wrong is super helpful. It'll help you get better scores if you slow down and really go through all the words around these codes as you're trying to figure out why you're only getting about 35% of them done correctly instead of all 50. I know you said that if we got stuck on a practice question to write it down, but how do you do that? Will that not be allowed in the coding books? There's nothing that isn't allowed in your coding books. It's your coding books. You paid for these suckers. They're yours. You can write whatever you want in there. You don't want to go through practice exam questions that AAPC sells to you guys and go into your books and technically write them word for word. What is an angiogram, or I don't know, whatever, and then put answer A, B, C, and D down and then just circle. Nobody wants you to do that kind of stuff. And no one who is proctoring an exam is going to go through all 3 books for 15 people there and analyze what you said or wrote. When you schedule your exam, you are given all this information from AAPC as you schedule it. And even the other day, I scheduled another certification exam through them for a different specialty. And if you just pay attention to what's on their website really close as you're clicking through the clicks, they tell you that there's no need to worry about what you've written in your books. Let me see. How do I... Is that it? Yep, that's the video. Properties. Let me turn that. Delete. Turn that back on. Yeah. So I scheduled an exam for September when I go to Vegas that I'm going to sit for. And I don't know if you can see this, but I posted it on my website. But the blue font, it just says right there what to bring. So this was right after I scheduled my exam. And it's just a pop-up on the screen. And it says, we strongly recommend you bring whatever books they want you to bring. But that blue thing right there, it says manuals will not be disqualified due to writing contained there within. Handwriting is perfectly fine. They tell you all the time that there's nothing to stress over about what you write in your book. Don't forget your driver's license. Don't forget this, that, and the other thing. I don't know where this wives' tale comes from about people getting, there's been no one turned away from what they have written in their books. And no one's going to be analyzing what you have in your books. And if somebody does, then you've got it in writing that you're not supposed to be disqualified for it. It's just ridiculous. I've never heard of anybody being disqualified from their books. But, yeah, you don't want to be rude and write every single word for word of what is in a study guide or what's in a practice exam question there. But they're not going to disqualify you for any of that kind of information at all. Anyway, if anybody's in Vegas, September, when did I do that? I think September something. 16th. I'll be in Vegas 15th, 17th. Yeah, 15th through the 17th. If anybody wants a meet and greet, I'll be there that week. We'll even be at the chapter meeting on the 17th. That's on a Saturday. It only lasts till noon, but if anybody's in Vegas, y'all come hang out. Y'all can pick my brain for sure. All right, what else was I answering? There was a ton of questions. That's good to see. I'm going to miss all your questions. Okay, let me write some notes down because somebody wanted ALS, and I have a question for that one. I'm working on the 36222 question right now. Yes, they will let you have peppermints. Maybe not for in-person or online exam. You want to have those unwrapped, not in wrappers with printing and writing on them. But yeah, in person, absolutely. But you want to take the wrappers off because you don't want them to make noise. So be considerate. There's the Discord group. Thank you, thank you, thank you, Twinkle. Put peppermint inside of water and just drink peppermint water. That's all you got to worry about. Peppermints have been proven medically to make people test better. Their scores are higher, and that could be the only difference. 2 days after your birthday. Yay. You can do, Aaron, a 26 if the doctor owns his own x-ray machine in his doctor's office. Or if a doctor is ordering another interpretation and then that doctor is only doing the interpretation but didn't shoot the x-ray, like the x-ray film was somewhere else, and then that doctor is being paid just to interpret the chest x-ray, then you can add the 26. But in general, it is global. The 4 hours does go by very, very fast. The chapter president brought donuts for us. That sugar rush will make you crash about an hour into it, so be careful. Yeah, it stimulates the opharynx in your brain, the peppermint scent of some sort. Yeah, so it's crazy. Yep, peppermint tea. Yeah, good question, Aaron. TC wouldn't really be used for chest x-ray. That's like a routine machine. It's not a nuclear device. Like some of these machines are going to be super specialty that are very, very fancy. And, you know, payers and what is really truthfully allowed is going to be totally different than what the CPC, AAPC, or a HEMA exam wants. So a lot of this is not real life. It's just pretend, and we have to know what answer is this question wanting right now at this particular time, and that's what we have to learn. Let me get that question from yesterday. Yeah, we're talking about oops, wrong way. I spelled it like checkers. Move that down here where we're at. Where are we at for today? Ooh, we're missing some stuff on this page. Just letting y'all look at this question real quick, see what you guys think is the answer. See if I can't get that higher for you guys. There we go. What is this one? This one is the 4.6 code. Seeing if I can't find you guys rationale to go with this one to help explain. Oh, wow. That's crazy. Sorry, just what I'm reading. What do you guys are thinking about the answer here? They are vague. Bookers, have you posted them in our Discord group? So if you're having problems with one of your questions, you can always post it in our CPC practice exam question room. Post it and ask for better rationale there. Somebody in that room will help you out. Because it's not a facility. We've got A with this one. TC is used for a building, not that the physician owns the machine, because that's the MD billing. Only a hospital or a facility can bill TC. A big university type building is the one that's doing the billing. That's when TC comes into play. 2.6 is for a human being who's reading the results, gets to bill. But that is vague. If it's done outside of a regular hospital, that doesn't mean that a human is billing that. It means that another facility outside a regular hospital, like a surgery center or the Ronald McDonald House, some building that is doing the building gets TC. A building that is doing the billing, that's hard to say. No, let's see. Try this one. Look at this one. Another rationale is really, that's the wrong one. That was unhelpful. That's not what I was looking for. Where's the one I was looking for? That was just an extra one. This was another one. This was the one I wanted to show. Push this one down a little bit. We'll deal with that one in a minute. This one. Look at all this. So we got a kid who swallowed something. And they're in the ER. Why is the ER billing 26? That's because we're billing physician services for the ER doctor. The ER doctor is going to read and give the radiology report, not the radiologist who's shooting the x-ray, but these are a lot of x-rays because we're shooting x-rays from the nose all the way to the kid's rectum. So we're doing cervical, we're doing thoracic, we're doing abdominal, we're doing tons of x-rays. And you see how they got the 26 on every single one of them, because the ER doctor is the one doing the interpretation, not the radiologist, the one that's shooting the x-rays. The 26 is on every single answer, so that's unhelpful as far as trying to pick out which one gets 26 or not, but I just thought it was interesting because we went from the nose to the rectum, so there was a ton of x-rays. But they're all getting 26 because the ER doctor, we're billing for the ER doctor, not for the facility. They are overwhelming at first. You can always post them in here too, like if you have one that you're struggling with. If it's a case, that's really hard to do in YouTube chat, but if you have one where you can post it, it's not too massive, because you'll have to post it in, okay, here's the answers, A, B, C, and D. Here's part of the question. Here's the rest of the question. Why did they come up with answer whatever? Because looking in the index is unhelpful. We don't have time for that when we're in the exam. But these are easy. I love these. These are easy, easy, easy to do. If you see something with a ton of answers in it like this, those are always easier than the other ones. So 60, is that in every answer? It's in 3 of the answers. This one's an outlier, right? So it's probably not the answer. But this one's got 3 of them with the 6, right? And then you've got 2 of them with 70. Then we've got another outlier. Why would you bill the 60 and then bill the 60 again? I don't know. There is a 1. There is a code difference there. Interesting. Now we've got the 40 and the 45. And then this one's got 40 after. And this one's got 48. Interesting. Would we do a 45 before a 40? Or would we keep them in syncs with 40 to 48? If we're going from nose to anus, where would these line up at? What would the codes in general, as you're going through there, be doing? Kind of interesting. That being our outlier. Code applicable for a child single view of the total body. Very cool. The other thing that I wanted to show y'all, where are we at? We're down here. Let me show you. We've got, what else was there from yesterday that had that same kind of issue? We had one that was that last one that we did. Seems like everybody got that one wrong. Where's the last one? Where'd it go? The 3 days in the hospital was good. This one. Don't forget that you got a lot of different modifiers in your HitPix book. Yeah. A lot of people got that one wrong. Just have to be careful with Quizlet because some of the answers are wrong because these are just humans typing in what they've done, and sometimes they type in the wrong thing. Even some of the answers on AAPC's practice questions every so often are wrong too. We do have a human element that puts these things in, so they can be wrong. Deep, I bet you passed. We're still waiting on your results, right? This one's G9. Don't forget you've got a lot of modifiers in the HitPix book. A lot of the process of elimination is not only looking for the similarities in things, right? And then you get rid of something that isn't the same. Another thing to remember is your answer going to be one or two codes? We've got one code here, two codes here, two codes here. And more times than not, the answer is the simplest, least amount to bill. Like with that X-ray one up here, if we only looked, where did it go? Did I already skip it? What did I do with it? What happened to it? I don't know what happened to it. Let me go grab it real quick. More than anything else, AAPC is trying to figure out who doesn't understand the coding guidelines, right? More than anything else, they want to know who is going to be an overcoder and who is not going to be an overcoder. So, and they're always putting stuff in their exam questions to make you think that you're having to do more coding than you think. So if we're going from the mouth to the anus, but we have a child, are we going to actually code 1, 2, 3, 4, 5 codes? 1, 2, 3, 4, 5. Are we going to shoot that kid with that much radiology? 1, 2, 3, 4, just to see if they swallowed something? Or are we just going to shoot one total view and see where the thing lights up at? Do we need individual throat, thoracic, abdominal, whatever else we can pick in on just a kid, you know? Or would we just do one view and see where the heck it's at, right? A lot of it is just seeing if they can scare tactic us into picking one with a ton of codes just because you think you need to code a ton of codes because the numbers are there. On that particular question, where was I at with that one? With the 27, let me find that one again real quick. Yep. A lot of times with their questions, you can just look at them and think, am I coding one code? This would be 4. This would be 6 codes. 6 codes or 2 codes. Well, the conservative one should bill only 1 code, right? No matter what's written, that's another technique to think about, is you just need to not be convinced that you have to code all those codes. That's one of the things that they're trying to make you think that you have to. We are doing 2 treatments for 3 days of chemotherapy. So your guideline with chemotherapy is you don't bill this. That's not what you bill for. Chemotherapy, radiation, that kind of stuff has to be billed prior, no matter how much you do. You're either going to pick one treatment, 1 to 2, or you're going to do the other code that is up to 5 or something like that. And it all has to be pre-planned. And if you did this many, and then the note also says, then we did an additional 1 more, you don't go pick the other code where there's just 1 treatment. You still just pick this code. It all has to be pre-billed and pre-planned, and no matter how much is added on to it, you don't add any codes to it. It's just knowing about that particular guideline here so that you know radiation is always just going to be, or chemotherapy is always going to be just 1 code, even though they've got all this stuff in the notes that make you think that you're going to have to do 2 times a day times 3 days. You don't do timeses on these. I can get you that rationale. 2 for this one. I haven't seen a lot of cancer treatments on the people's feedback of what they've seen on the exam, but I don't know. You guys tell me. Have y'all seen a lot of chemotherapy or radiation on the exam? That's the rationale for that one. E&M, the scores have been falling down on those for sure since we've switched. I think coding E&M is a lot easier now, but a lot of people are struggling with it. E&M of course, is billed with time or MDM. And if it's time-based, one of your rules is if you have a code and then it has an add-on code for more time. So like code 1 is for 1 hour, and then the add-on code is for additional hour. The one rule of thumb there is that half the time has to go by and go by. It has to pass before you can use the additional add-on code. So if I have chemotherapy that lasts 1 hour and 30 minutes, then my answer is just code, no add-on code. If my chemotherapy is 1 hour and 31 minutes, then my answer is code with my add-on code. So that goes in play with codes that mean 30 minutes. So if a totally different scenario, if one code's time is 30 minutes and then its add-on code for an additional 30 minutes, then that means if we had 1 hour, is that right? No. Let me think. So we got to do, if we had 45 minutes, then the answer is just code. But if we have 46 minutes, the answer is code with add-on code. Because you got to have half the time go by. Once that goes by and you've added more time to half the time, then you can add on the add-on code. Does that make any sense? Some of our codes are 15 minutes codes. Oops. And when it's 15 minutes, 15 is divided by 7.5 is our half time, which you have to do anything over, 4 is reduces down, anything over 5 or 5 goes up. So 8 minutes have to pass before you can start to bill for something else. So if we have 23 minutes, is that right? Equals code, right? If we have 24 minutes, 24 plus with code with the add-on code. I don't know if that's correct, but I hope so. And that's supposed to be 24, right? I don't think so, Erin. She said, Jen, do you think AAPC is catching on to your methods and approaching with their questions and trying to combat what your approach is? I don't, because they're teaching my approach now. They're actually charging for workshops and teaching my methods or things that I have already been saying for 2 years, and they've never done that before. And even just last week, somebody attended something and then they got back to me and they said, your methods were all over this workshop, but they said your notes were overkill, like it's way too much, but it was cool. But, you know, so they know about me, and they know honestly what is truly going to help and what's not going to help. And they wouldn't be teaching it now if they didn't think it would not help some. I mean, you know, so yep. So I'm glad to see them testing some of my methods and putting them out there, but do I think they're rewriting all their questions? No, I don't think they're rewriting their questions, because, God, I can't even get them to fix their questions from last year from the guideline issues. They've got a lot of other things in their buckets they're dealing with than to deal with just me, but I enjoy seeing them, incorporating them. And because of the way my brain works, I can see patterns where other people don't see patterns. So y'all may not be seeing things that I see too. So it's just differences in the way everybody sees everything. So it's just a helpful tool. It's not going to work on every single question, but I can make things work in questions too that is different. But there's a lot of different tools to use. Okay, so this 15-minute or half rule thing for time is one part of E&M. It's a crazy one. That's why in chemotherapy or infusion therapy, before you add on that add-on code in infusion or hydration, an hour and 31 minutes has to pass before you add on that add-on code, even though the CPT code descriptor for the first code says 30 minutes to 1 hour, some craziness like that. That's what this code says. And then the add-on code will say for the additional hour. But you don't know, by the way this is written, that an hour and a half has to pass before you can add on that add-on code. It's crazy. Anyway, for MDM, we have three what now? We have three elements. I always forget about what they're trying to call them this year. Three elements, the number of problems, the number of data reviewed, and the number of the amount of risk. So inside each one of these elements is 4 more things we got to worry about. Let me get to the proper wording here. So inside each one of these elements, we have where the words straightforward comes into play. I guess we'll figure out how to spell that in a minute. Straight, F-O, oh my Lord, what am I trying? Farquhar. What am I trying to spell? There we go. Straightforward, low, moderate, and high. To meet each one of those levels is each individual. To meet that level, to meet that level, to meet moderate is its own little thing. I-D-E-R-A-T-E, what the heck? Okay, and then, so they each have their own branch. Each one of these has its own branch. Straightforward is very, very low, probably very little direction, like go home and rest. This might be OTCs, over the counter. This might write you a prescription that you're going to start taking every day for the rest of your life. 30-day supply with 12 refills. You know, it's going to change you. You're going to take a pill every day. And then high means decision for surgery, or we're doing something major. We got to intervene because your life is in danger. And if we don't intervene, the likelihood is going to be you're going to not make it. So we got a huge increase here. And that's for each one of these different elements. We have to figure out, is the problem straightforward? Is the problem low? Is the problem moderate? Is the problem high? We also have to figure out, is the data straightforward? Is the data low? Is the data moderate? Is the data high? Same thing for risk. If they're an established patient or a particular MDM that doesn't need the difference between new patient or established, we have to meet 2 of 3 of these to bill a particular MDM element. So what that means is if our problem ended up being straightforward and our data that we reviewed was low, but we feel our risk is higher at moderate, you're going to have to figure out what you can bill based off that if they're all different in different categories. And you need 2 of 3 to match. So if you have, goodness, let me think, 1 in straightforward, 1 in low, and 1 in moderate, what would you bill? Well, think about straightforward is also in low, or no, yeah. We had a straightforward problem that increased. It's kind of like how I think about it. So straightforward is a combination and inside low. So straightforward is in all of these, if that makes sense. But low is in this one and this one. Moderate is only in this one, right? Does that make sense? So if the problem was straightforward, the data was low, and then the risk was moderate, this is how I see it in my brain, that straightforward is in all of them, low is in 2 of them, and moderate is only in 1. And if they're an established patient, I could bill low because I have 2 that match up. Super confusing. This isn't anything that I think that AAPC is going to make you do yet. It's how they used to do the 1995 guidelines. That was crazy with the 2021 guidelines. It was a mixture of all this in 1 or 2 of their questions, but they haven't started in on this yet for E&M for right now. The only thing that they have done is trying to get you guys to do at least just this for overall MDM based off of what the plan was, what the doctor did and ordered. So it would only be risk by itself that they would be asking. So if they ordered the patient to rest, but then they ordered a ton of lab tests to be done in the next 2 weeks that ended up being moderate, and they wrote a new RX that was moderate, you can see how they would bill moderate even though the problem of it was straightforward, but then the data that they reviewed or ordered was moderate, and then the risk would end up being moderate because 2 of them ended up being moderate because of the RX and the amount of tests that they ordered. It's probably as clear as mud, right? Love Muffin, good job. Yet. Yet. Yeah, they haven't, not that I know of. In my E&M, I'm trying to come up with, over on like page 13, underneath 99202, I put self-limiting, small mass, no treatment, abdominal pain, nausea. Another example I put was like bandage, rest, those kind of things. Under 203, I could put atrial fib, a UTI, a simple mastectomy, an acute illness like bronchitis, maybe 7-day RX, something you'll get over, that kind of stuff. And then the 203, I put diabetes with a UTI. So I have one chronic and one acute illness. 4 labs ordered, like an ultrasound. You know, I have blood work and I have an ultrasound. Meds to reconcile for the 204, like if I've doing your 30-day prescriptions and doing refills for the next 3 months, that kind of stuff. If I'm doing steroids, injections, those kind of things can be of moderate risk. 205, severe exasperation of things like CHF, chemotherapy management, discussion over reducing a risk for breast cancer, like we've decided to do a mastectomy and do a total reconstruction. But this is only because you have some gene in you that gives you breast cancer or cervical cancer. Well, we're going to do a total hysterectomy and we're going to do a total breast removal. That's pretty extensive. And the risk of complications to that patient is pretty extensive too. That would be an example of 205. I think that's like the best thing to do is just to go to each one of these CPT codes, and we've got a little space underneath each one, write some sort of conditions or things that we find that could help out in these areas. The main thing to remember is a lot of times no one gets consults will be the next thing that we got to go into in E&M. Most patients never qualify for a consult, even in hospital situations. We had a crazy question last night. Ooh, what was that question? I think everybody got wrong. Somebody was in the hospital, right? I don't know where it's at in this chart, but everybody got that one wrong. 3 days. There was 3 days of hospitalization. Let me see if I can find it real quick. Let's see. Oop, wrong one. Let's look for hospital. this one right here. Let me erase all my red marks from yesterday. All my red marks. All right. So right here we've got admit hospital, subsequent hospital, hospital consult, and admit hospital. You've got two that are similar, two that are different. During a course of a hospital admission, MDM requests an orthopedist to see a patient for a bone osteoporosis. The orthopedist sees the patient on day 3 of the admission and performs an appropriate history and exam, the evaluation of the patient's osteoporosis. The doctor orders a test, the bone density study, and prescribes the patient Boniva for the patient, which is a prescription they do take every day for bone loss. What would we code for the orthopedist? What do you guys think on this one? Good night. See you later. How's what graded? Good night, Gupta. Hey, PC. Good to see you. Patient's been in the hospital for 3 days. It's going to be admit hospital, right? Another rule of MDM or E&M is that if there is a different subspecialty, then you get to bill your patient as seeing your patient. So whatever this patient got put in the hospital for, it definitely wasn't because of osteoporosis. Who knows what it had been. Something catastrophic to be in there for 3 days. I don't let nobody be in there for 3 days, but it definitely wasn't because they have osteoporosis. That's not a reason for admit. So it could have been a cardiologist. It could have been a neuro doctor. Who knows? But this is a different subspecialty. An orthopedist would not have been the one that admitted them. Could have been renal failure. Who knows? This doctor wasn't asked to see this patient as a referral. It was just during a course of a treatment. Hey, you should go talk to this patient. It wasn't, I need you to go see this patient and take care of a particular problem for me, and then let me know how I need to treat it. This wasn't a referral. So we're not going to do the hospital consult. It's not a subsequent because this doctor was not involved in the admissions. If you have at the date of admission or in the ER an admitting doctor call in a specialist during the ER visit, and the admitting doctor asked a specialist, what's your opinion on this patient? Should we be, doing this, this, and this? And they both concur. Then this doctor bills the 211 or 221, sorry. And then this doctor would bill a 232 for their involvement in the admission. But this doctor was not involved in the admit and was just asked to come give their opinion on a patient due to their speciality, not because it's needed, but just because. So this doctor gets to bill because of their separate subspecialty and admit code, which is so much fun and threw everybody off yesterday. Just remember to consider that the patient's been admitted to the hospital for 3 days without even seeing this doctor, that means it was admitted for totally different reasons, which means it's got nothing to do related to this admission. So, yep, different subspecialties. All right. I have a question too here about the ALS that she asked about, the ALS. No, ambulance. Yep, this one. About the modifiers for the ambulance. I did this one in the workshop too. Be sure you know these for your medical coding exam. I bet you're going to see these again. They are not in the CPT book. They're in the HitPix book. And so are these codes in the HitPix book. So if we look at our HitPix book and we first worry about the codes, 26 is ALS. This one's advanced. 29 is BLS. 27 is ALS. And 29 again is BLS. Right? And so is 28 BLS? Yep. So first, look through your question and see if we did basic or advanced life support. We did basic, so we'll get rid of anything that is advanced. And then you just need to find out, are you a QM or a QN? And those definitions of those modifiers are in your HitPix book. What do you think the answer is for this one? That's what I'm hearing, Jen. So I found this one on the internet and thought, that's cool. Now, I think I'm not explaining well tonight, but thank you, Love Muffin. You're awesome. I'm trying. The exam, the certification exam, is 100 questions. So you got to get 70% correct. So you can miss 30 questions, right? And that's it. If you miss 31, you don't pass. I think that's how they do it. AAPC does their exam. I'm sure they got tons of info on their site about that. And there's your answer on this one. Let me get down here to the ones that I had prepped for tonight. Where am I at? Oh, come on. Here we go. Yeah. Some of these. Close, close, but no cigar. There's the Medicare one. Love it. Adjacent tissue. All right, what about this one? Some people say something about this being on their exam sometimes. So I thought I'd get you a question made up with this one. Anybody else see that word on their exam? You don't understand SH? SH. Have you looked in the HitPix book to look at the modifier differences? Because they're pretty self-explanatory in the HitPix book. So what are we looking at? SH. I like looking at the back cover because it's smaller. SH. SH. Where are we at? That's second concurrently administered infusion therapy. So you know that ain't got nothing to do with ambulance. This is in the back cover, but a lot of times in the HitPix book, it's got, yeah, you can't, yeah, all you gotta do is go look it up, and they have each one in its own little box somewhere in this HitPix book. Each HitPix book is designed differently. So if you just go look them up, SH, again, it says right here, second concurrently administered infusion therapy, nowhere near an ambulance. So you know SN means third surgical opinion. On that one, what was some of the other ones? They were NH or QN. But yeah, all the modifiers are all listed in the HitPix book. And they're not bad. They each have a header. And you just read your little definition and see which one goes along with whatever the question is dealing with. There's a ton of them. I like the AAPC's version of the book of the HitPix because they have a front cover and a back cover that has all of them listed in shorter little flappy flaps. They're all listed, but there's a million of them, all the way from AA all the way to Z something. But there's a million modifiers they could ask you about. Yep. Should be in your HitPix book. They're not bad. Ambulatory codes. Read the paragraph. It explains what the S stands for. Good gracious. Support. The only ambulance modifiers or ambulatory over here is the QM for ambulance services and QN, which is ambulance services. One of them is directed by a provider, like a provider owns their own ambulance. That don't ever happen. Or whether it's provided by a service. So those are the two ambulance services that I know about. There are no S ones in ambulatory, but Oh, they're using abbreviations. Ah. Yep. Two different meanings. Yep. Yep, there's a modifier for that. There's a million of them. And see, in that particular question, it was all about modifier. All right, this particular anatomy part has been on recent exams, probably. Maybe, maybe, maybe. Supposed to be 3 questions on hip picks. And Erin, I think she just got a 100 on her hip picks. She knows what she's doing on hip picks. Smallest part of the exam. This one, yes, is I. Who got that one right? Dawn did. Good job. Be sure you know where retro is. I've heard about this one being on the exam or something close or some sort of question about cataracts. What is that? Ooh, it's trash cans. Got to go out tonight. Trash night. Dang advertisements. Yep. This is what can cause cataracts. This can cause cataracts. So if they ask the question, what causes cataracts? This can cause. This one is how you can treat them. You can use a laser to fix them. And this one is glaucoma, something totally different. There we go. Ooh, I like the little hearts you can make go. Love that. It's cute. All right, let's try to give away a subscription. All right. What about a physician performs this particular procedure? What are they working on? Again, another key term. Make sure you know. The clouds parted. I see the light. Aw, yay. Time to party now. Yay. That's so funny. I'm talking about one thing, y'all talking about something else. So funny. Y'all got the answer to this one yet? I got A's and B's. A's and B's. All right, Brittany and Mary. Awesome. Congratulations, guys. I hope those memberships help you out. This is about our Vajay girl. Remember that, because it is probably going to be on the exam. I don't know how you can associate. Maybe remember that the Y kind of looks like a V. I don't know. Find a way to remember. I don't know. We can make a face and go, ooh, no, you ain't going there. No. I don't know. Got to remember some way or another. What about the lobes in the lungs? This question, some way, shape, or form, is going to be there for sure. Depending on which exam you get. I got B's and C's. Hi, Melissa. Yep. Be sure and pay attention to whether it is right or left or all lungs, because it's different answers. It could be all kinds of different answers. So, yep, we got 3 in our right, we've got 2 in the left, and altogether we have 5 in total. So be sure you know where we're talking about. Lacrimal gland will be on your exam for sure, but they may call it something different, like that DA cry thing. But it's responsible for what? Agents, production of zombies, it almost reminded me of. Welcome to the club. Yay! We got even more. Thanks for supporting the YouTube channel. Appreciate it. And I hope it helps you out. You got access to all the book prep videos. You can watch me book prep code to code, or you also have access to the workshops that are older than 90 days. I now have a podcast going too, where I'm reading the CPT book to you and just talking about what I think each sentence means in layman's terms. I don't know how helpful it is, but I hope so. This one is production of tears, of course. What about the function of the thyroid gland? Can you remember what its function is? Is it for metabolism and calcium, insulin or hemoglobin, immune and calcium, or mood and hormones? I keep looking for associations. I see 2 answers that end in calcium. What do you think? Sam's now got a membership. Yay. Awesome. Yep. A is the answer. Good job. Metabolism and for calcium, blood calcium. Good job. All right. What about this one? We have ER, consultation, admit hospital, and ER. If you don't know your E&M codes that fast, by just looking at the numbers and knowing where they're at, then work on that, because that will help you during your E&M part of the exam for sure. So we got a girl who twisted her arm on the playground. She went to the ER. They did an x-ray. They gave her an assessment, and here's her plan to do OTCs and hot pack. What level visit are we going to give her? Under which header are we going to be? We're going to be under ER, consults, admit. Anybody see something like this on their exam? Suzette. Let me go back for you. So our answer was C, because it was asking what is a cataract, and that's just an opaquency, a blockage, something that is impeding your vision. What's going on in your eye is inside your eye, your cartilage, the things or your cells that are making up your eye are slowly doing like what my face is doing, falling off of its skeleton, so they fall, everything falls. So you got little pieces of a collagen that are falling off of all the parts of your body, and they're just kind of getting in the way of you seeing. So it's impeding your vision. But I also put in the answers, because I wrote this question today. This is how you treat it. This is how you catch it. I'm sorry. These kind of meds can make you have cataracts if you take too much steroids. Some antipsychotics can give you cataracts. This is one way you can treat it, is with a laser. And then this has nothing to do with cataracts, but everything to do with glaucoma. So that was probably confusing since I was putting other stuff in there. Hopefully that's helpful. Our little girl, she just twisted her wrist. What are we going to bill for this one? This A is an ER nurse visit only. It has been changed since 2023. So this is only for a bandage change. We definitely cannot bill this for a physician who ordered x-rays and gave an opinion on whether this kid had a fractured wrist or not. So we cannot bill a nurse visit. This is a office consult. We are not, the patient status means where is the patient? The patient is not in a doctor's office somewhere getting a consult, so we can't bill that one. This patient's status again has not been an admission into a hospital. An ER is not a hospital. This is just like a clinic, outpatient center, and it is not a hospital setting, so we cannot bill hospital. So our only real option is to bill our clinic, our ER visit, which is a level 2, which is the lowest ER MD visit we have now, because we go all the way up to 05. Remember, we have those components of straightforward. That's what 82 is. 83 is our low. 84 is our moderate. And then our 85 is high. Still our components of MDM. Now they're all in a neat little category in our ER now, because they've given away this code to be a nurse visit, just like our 99211 code is also the only other nurse visit. And we don't need any MDM or time with these, because these are just staff codes, not MD codes. They are for staff or clinical staff to use. They are not for an MD to use. Don't we all need some antipsychotics? I need those mushrooms. I need those whatever. I need it all. Yep. There's this song my mother loves to sing. I don't know who sings the song, but it's something about I need a better drug. Y'all know that song. My mom loves that one. Anyway, it's funny. All right. I'm too chicken to take any of it, though. Emergency and straightforward. And I got one of those brains. None of that stuff works on me anyway. Whatever it was. Never did see the hype in it. All right, what have we got going on here? We either have a diagnosis or we have symptoms. We probably cannot have a diagnosis with symptoms, so I would be like on that. And yeah, let's go look up our E&M codes back, or not E&M codes, medicine codes back here, and see what our differences are on these codes. 946. We're way in the back in medicine. 946. You gotta get to these codes quick. Can't be slow like me. All right. What are we doing? Breathing treatments? Yeah. 94640. So just thinking about AAPC, what they want us to code, or what they're trying to figure out. Are we a low coder, conservative, or are we an over coder? Just looking at the numbers, you know 40 is the cheapest one. It'll go up higher with the 42 in price. The 44 is going to be most expensive out of all of these. So think about that kind of stuff too, is what goes on in my head. I'm already liking C. I don't like D because it adds way too many codes together. My differences, 40 is pressurized or non-pressurized inhalation treatment. 42 is aerosol. So we've got pressurized or inhaled. This is aerosol. And 44 is continuous? What did we do? When we look through here, what did they order for a kid who has a bark like a seal? What do you guys think? Thank you, Twinkle. Drug of choice is caffeine. The only thing is that I don't like the taste of coffee. Never have. So I'm not really good at caffeine drinker either. It's crazy. Just terrible at everything. The only soda that I like to drink sometimes is root beer because it's not bad for your teeth as far as enamel goes. Tea's okay, but it stains your enamel. Water's always a good option. How do y'all come up with that answer when we don't have continuous, aerosol, we don't have the word pressure or inhaled in here? How do y'all come up with the 40 when nothing's really listed in here except for nebulizer breathing treatment? I'm just thinking from .40 is the only one that has nebulizer in it, but it is a well-hidden word. That word is like buried in the middle of, Lord, it's bad, but it's buried, but it's there. It'd just take you a long time to find it if you hadn't found it before. So be sure and pink highlight the word nebulizer in that 40 code. That's helpful because your one word differences aren't the word that you can look through this question and pick out which answer it is. We just have to answer with the nebulizer. Yeah. On that one. I don't know what they're talking about a guideline for, but they're talking about the diagnosis, not the CPT code. That's why. Somebody with the croup can't be coded with signs and symptoms is what they're saying about the guideline. So that's cool. Not needed since every answer really technically is different. And if you just get the CPT code correct, you don't have to worry about the diagnosis, which is helpful. All right. What have we got here? We've got 2 with the same CPT code. Just need to know, would we add another CPT code to it or not? Or would it be by itself? Look at its ICD-10 has 3 digits, where if I did do A, this one only has 2 digits. You really want to code out your diagnosis all the way to the 3rd, if possible. Just one of those things. They really like to pick an answer with 3 digits instead of 2 a lot of times. Just thinking out loud about if I was to not look up anything, what answer would I like before I even did anything with this particular question? What do you guys think the answer is? Cinnamon is good for you. Less than an hour, use code 40. Nice. There's those parentheticals that are down there. There was probably no time in that question, too. Good answers. I think I remember that question being on my exam, but that was a long time ago, back in, like 2019. Cinnamon is really good for you. Anybody going to try to answer this question? What have we got going on in this one? We're doing a small incision between the ribs. What is that called? This one is a thoracotomy. No, a thoracoscope. It's a scope. Scope. And it is diagnostic. 50 is surgical. Are we doing diagnostic or surgical? Might be helpful. Let's see. We've only got 2 digits being used. I can't even find our 2560. Where are we at? 2560 is our inhalation chest tube for a collapsed lung. Is that what we had to deal with? Small incision. Yep. We weren't doing any scopes at all. That made things a whole lot easier because there was no scope. We've got no trocars, no cameras. We just have a catheter being inserted. Yep. Makes it a whole lot easier. Those are just a mammogram one from yesterday that we had. The other ones that are sometimes on the exam is the differences between the 32552, 54, and the 55 and the 57. If you were to have to do something in these areas, we've got the 57 is a drainage The 5-5, that's the thoracentesis. That's for aspiration. So's this one, but one's with imaging, one's not, yeah. And then the 5-2 is just a removal. So find out, are they removing something, or are they placing a drain, or are they just aspirating? Whatever their question is, it's pretty confusing, and these two are one's with imaging, one's without, but I haven't found it yet. This one is mammogram, right? We're dealing with, we've got two of them. It could be with the same diagnostic versus screening, and whether we would do unilateral or bilateral or whatever. Yeah, because some of them could be just one side, especially if it's diagnostic. 770 65. So this one is diagnostic. 66 is diagnostic. Bilateral, unilateral. We would not bill this at all for any reason because it has a bilateral code. So that's a coding irregularity. 66 is bilateral. You wouldn't add a 50 to it, would you? Because it's bilateral. That don't make no sense, does it? Yeah, no, you wouldn't do that neither. And then 67 is our screening. So, are we screening or are we diagnostic? Let's check our question. We're diagnostic, and we're doing it on both. So it would only be B, I think. What do you guys think? There we go. Get them on both on the same page. Last one and we'll go. B, everybody say B. Yep, B is it. There you go. I just got to retype that one. Very cool. All right, guys, I hope tonight's been somewhat helpful. I know I've been crazy and bouncing all over the place, but didn't have a whole lot planned because I had the workshop yesterday. I will go get that posted up in the store if anybody still wants to purchase it. I'm going to be in Vegas tomorrow. I got to get John's car serviced, and I'm not sure, but we do have sort of a family member who is in need of some pretty emergent help right now, and we may end up going to go help that person. We'll see, but I will let you guys know for sure through Twinkle. So if I have to go, it is to help somebody in real need. So I will carry you guys along with me though, as usual, but hopefully I will see you guys on Wednesday to do another 2 hours of free practice questions. We'll do some more. Be sure and post in our Discord group what type of questions you would like to see me go over That way it helps me get ideas on what I haven't covered and what I should cover to help you guys out. I know I've got a couple of more posts in there that I need to go over and grab some more material for. So I'll get those done for Wednesday, and if there's anything else y'all would like to see, please post it in there. I hope to see you guys there. Any other questions before I go? They are always bilateral for screening. That's right. Always, Blondie. Good job. All right, guys. I will see you on Wednesday.